few decades ago, we were mainly the trauma surgeons, but now the non-traumatic and degenerative orthopedic conditions have increased multifold. Most of the OPD patients are of this particular type. What in common Indian patient, as I said, he exposed, especially the rural population and the middle or the lower socioeconomic status patient, they want sustained and long-term pain relief without surgery. He's scared of a surgery. He considers surgery as last resort. So when advised surgery, other pathies lure him by tall claims, and some do get satisfactory result, but at least over a short period of time. But then the allopathic science is criticized, and doctors are accused of the looting and knife crazy because they get good relief with the patients get good relief without surgery. Especially after surgery, once patient has operated, he has already spent a lot of money for the surgery, so the expectations from the surgery are very high. And there is increasing number of dissatisfied patients after the surgery, especially when it is done for the degenerative conditions, the spine, shoulder, and in early arthritis in the knee joint. Early arthritis I'm talking. Especially expectation from surgery is not fulfilled. This particular column is from the Times of India, and Swaminathan is a very renowned person who has written this column. But he has said that to combat severe spinal arthritis, I underwent major surgery on my back last year. The surgeon reconstructed three vertebrae using the titanium rods. Also, 1.5 years later, the pain is almost as bad as before. On every post-operative visit, he takes an X-ray of my back. He looks admirably at his handwork, almost as though he's in love with it. It looks really good, he says. Sorry, I say, but the operation was supposed to take care of my spinal pain, and it hasn't done. So don't worry, the X-ray shows you are doing fine. You will get better in the course of time, says the surgeon. Giving the X-ray another admiring look. The last sentence is important. The operation has left the surgeon delighted, but without satisfying or curing the patient. This is a scenario we see in the most of the patients who undergo certain surgeries. So what is solution? Can you find any conservative modality which will give long-term relief and reduce dependence on the NSAIDs? As I said, local corticosteroid injection is one of the most important tools to treat such patients. But I repeat again and again, it should be combined because it gives to you the relief initially, but then it should be maintained by the hitting, proper exercises. Proper is an important word, back care and the joints care. There are different types of corticosteroid injections, intra-articular and the local. The local are two types. One is with needling or without needling, and third is the epidural one. This is indicated, I have told in the morning that I will just go through very fast into this. In intra-articular and degenerative arthritis, especially in the knee joint, ankle, hip, first carpometacarpal joint and temporomandibular joint also. It can be given in all the joints, even the interphalangeal joints also. Especially in the chronic pains in the shoulder joint, you see all these reports on the MRI for the chronic shoulder pain, small tears, tendinosis, impingement, and non-infective inflammatory synovitis from hip to IP joints. As I said, TM joint also, especially fibrous ankylosis. That is intra-articular. Local without needling, one can give in tenosynovitis like Dickervans, peroneal tenosynovitis, tibial posterior. In tendon sheath, one has to find, especially for the Dickervans, that never give in the tendons. Again, the feel of giving while giving the injection is important here. Any, let it be tendo-HLS also, never give in the tendon. It should be outside the tendon. And in bursitis, retro-HLS, one has to be very careful, as I said. It has to go only subcutaneous, otherwise patient chances already are more because tendo-HLS attrition is there in the retro-HLS bursitis because of even the Hageland prominence. So one has to be very careful. Then trochanteric bursa, subcutaneous bursa, ganglion injections. I will come to that later on. Then other injections is with the needling. So when there is a problem at the junction of the muscle and the bone, that is in periosteal area, enthesopathies or the insertional tendinopathies, either in tendon, fascia or the IT band, in tennis or golfer elbow. Again in the plantar fasciitis, in the morning it was said it is right, it's the most painful injection. So I give a block of the foot block first, and then from the medial approach I go, not from the plantar approach. Then costochondritis or the Tietz disease, osteochondritis like Osgood-Schlatter, navicular tuberosity. Then on painful osteophytes in the medial of the knee. Then chronic sprains, patient is having ankle sprain at least 4 to 5 months before, and still he gets pain, especially at the either talar or the fibular attachment of the ATF. What a successful sign of the injection is patient gets immediate pain relief because the lignocaine is there. One thing is the pain relief is not for pain relief. It is a sign that you come to know that the injection has gone at right place. Now of the back injections, especially the fibromyalgia injections, there are many spots which are told about the fibromyalgia. It is in the upper limb it is either brachial neuralgia, and the lower limb is general word is used as sciatica. In the sacroiliitis also, the injection can be given in coxgodynia. What the previous speaker has spoken about the nerve block is not required. It is again a point, insertional point at the end of the coccyx. Then I give a lot of epidural injections for the spinal pains without neurodeficit, especially for small PIDs and in spinal canal stenosis. Spinal canal stenosis is a degenerative condition which increases day by day in the old patient. So there is no need to operate them immediately. If you operate for spine canal stenosis at the L4, L5 or L5 S1 level, they are likely to get again stenosis at the L2, L3 and L3, L4 level, or even the recurrence of stenosis. So it is not a permanent surgery. So one has to try to avoid surgery as far as possible, and surgery is the last alternative. Then again, contraindication I told you, infection anywhere and uncontrolled diabetes mellitus or immunocompromised conditions. These are the precautions I told you before. Again, same thing about the joint injections. Generally for shoulder and hip, I use arthrography, which I shown here. And for wrist ankle, I use the image intensifier so that you are sure that you are into the joint. This is the ankle. You can see here, all these are arthroscopy portals. The best site of giving injection in the joint is arthroscopy portal. This is the anterolateral arthroscopy portal. You are between the fibula and the talus. Then for shoulder, I use a dye. Here you see two different arthrographies. Here you can see the inferior pouch. This happens when there is intraarticular pathology but no fibrosis. But in capsular hyperplasia or the shoulder, frozen shoulder, you won't see the inferior pouch. But this is I first confirm here and then I put the injection, because injection should not go in the soft tissue. It should go into the joint. As I said, it is arthroscopy portal I use for anything. Let it be wrist, knee, shoulder. Aspirate joint whenever possible. This I told already. Actually, these are the videos, but now I got much less time. Intraarticular injection takes hardly 10 or 15 seconds, much less than that. On the anterolateral portion. This is the intraarticular injection of the wrist, which I do under the image intensifier. This is the ganglion, immobile. I'll just show you this particular video of this ganglion, because I have not operated a ganglion in last 30 years. All patients do very well with this video won't work there, but I think it will work here. Oh, why it is not working? Yeah. So, sound is not there. Sound येत नाही ना? हो का? Surprising. काय आता anybody can come out of that? काय options काय असतात तुमचे? एम्बेड केला व्हिडिओ, त्यामुळे तो दिसला पाहिजे काही. माझी ते व्हिडिओ रन होतोय, तिकडे गेला पाहिजे. त्याच्यात ते आहे का फाईलमध्ये? Can you get a sound now? The video is working now. See there. Okay. Now here it is a volar. I deliberately took the volar ganglion. But wait, the video will work. Here in the full screen, the video is not working. That's why I took that for the small screen. Okay. I deliberately took the volar ganglion because it is on the radial artery, almost near the radial artery. So you have to feel the radial artery. Okay, and this is why I am feeling the radial artery. And when you are inject, video पर नहीं दिख, अरे मगाशी दिखला था. नहीं फुल स्क्रीन नहीं आता था, मैं I took a small screen. हाँ मग ते परत ह्याला मी करून बघतो. क्रिएट केल्यावर येते. You are getting now. Sorry. So. One has to go parallel to the wrist to avoid the injury to the radial artery. Okay, and I take a little bit more solution. I dilute with the normal saline. The volume should be more. You go on injecting, initially it goes easily, but later on you get a lot of resistance. because the injection is going in the ganglion. Okay, there is a sebaceous fluid inside. Sebaceous, it is like a cyst, and the moment you give more pressure, it bursts open. The ganglion has to burst open, and all the content of the ganglion they diffuse subcutaneously. But that is the key. Patient can get some inflammation for 1 or 2 days, but they at that site the recurrence doesn't occur. It occurs somewhere else. But the chance of the recurrence is hardly 3 or 4%. But all of us know that even after doing the surgery of the ganglion, the chances are 4 or 5% to get back again. So one can give the repeated injection rather than doing repeated surgery. But I have injected in one of the patient, lady who has already done thrice surgery at that spot, but it recurred again on the fourth time. I myself have taken injection in my own ganglion at 3 different places, but I have not operated. Last time I operated ganglion around 30 years ago. Actually, that video, that is a very nice thing to see. Immediately the whole thing gets flattened up. Again, tennis elbow. Those doctors who are giving injection, you realize that at the insertional site there is a chondroplasia. I mean, there is a metaplasia and a chondral tissues form. When you are injecting there, you get a grating sensation. And that's why you have to do the multiple needling at that site. In that particular grating sensation, the moment you go into the soft tissue, you will not find the injection not effective. It should go into that cartilaginous metaplasia. I have given at Gurley's tubercle also for the IT tendinitis. This is, can I get few minutes more? Yeah, I requested, yeah. So there are multiple fibromyalgia points, but there are specific points in the subscapular as well as in the lumbar area. In the lumbar area, it is the posterior superior iliac spine. Here, this is the area. Here you can get the multiple nodules also, but there is only one nodule which is painful. And in that painful nodule, the injection should go, not in the nearby nodules. Okay, and again, there multiple needling is important. In the cervical, it is superior medial angle of the scapula. Only this particular point which is there, which is all these points are mentioned in the books, but this is the one which is very important for giving the injections. And in the cervical area, basically around 70% patient has got a psychosomatic stress. That's why for the further prevention of the recurrence, this treatment is also necessary. As I again said, point of maximum tendon is important. These are very painful nodule. Reach up to the bone, not in the fascia, the injection, because they are saying it is a myofascial. No, it should be at the bone, at the junction of the muscle and bone, and multiple needling, grating sensation is necessary. These are the actually videos how to give that PSS as a scapular injection. Last thing is about the epidural injections. For the PID and spinal canal stenosis without gross neurodeficit, I go by intraspinous route in the sitting position. Of course, one has to inquire whether the patient on blood thinners or not, because if the epidural puncture is there, then that bleeding can cause a lot of problem. Remember, this epidural injection takes maximum 3 or 4 minutes, not more than that. It is a daycare procedure. We have to watch for vasovagal or the temporary hypotension. This is also video of the epidural injections. Within this video is hardly of 1 or 2 minutes, but how to do that? It is very easy. I give around 3 to 4 injections per day of the epidural. These are all complications we have discussed. Delayed complications are almost nil, except the white spot when the injection is in subcutaneous area, like the decurvans or in the ganglion. Then it can last for almost 6 months, but if you counsel the patient properly, they don't complain about it. Rather, we took in the consent also. We take that in consent that you can have a hyperpigmented patch there. But that patch is much less with the methylprednisolone as compared to the triamcinolone. Cartilage separation is feared of, but it is a transient one and is reversible in the 3 weeks. All these are advantages of the giving the injections. OPD procedures can avoid surgery in about 90% of patients and can postpone surgery in many patients. We can buy the time, and of course it can be repeated many times. It is highly cost effective. It gains the confidence of the patient. As I said, patient is accusing us of the knife crazy person, but here patient thinks that you have given him the chance of getting relief without surgery, and still patient is symptomatic, then one can go for that. Again, limitations are there. Accuracy is very essential in certain injections. Over a period of time, once you practice, it is easier one. And duration of the relief depends upon further multimodal therapy. And positive efforts had to be done by the patient to prevent this recurrence. This I have already told you. I am giving at least 15 injections, including epidural injections. This is important post-injection maintenance therapy. There are review of certain patients' papers. We'll just keep that off. So again, same thing I told as in the morning, surgery is the last option. Intraarticular injection do help. So we should give the patient a chance to avoid surgery as far as possible. Thank you.